SIADH, or Syndrome of Inappropriate Antidiuretic Hormone, is a condition wherein there is an excessive secretion of the hormone ADH, or antidiuretic hormone. What is the pathophysiology of SIADH? Well, there are three mechanisms most often responsible for the production of SIADH. And the first one is inappropriate secretion of antidiuretic hormone, or perhaps there's some other area that is producing ADH. And this exactly is what happens when you have some forms of tumors that secretes ADH as well. And the last one is there might be an exaggerated action or enhanced action of ADH in the distal tubules. Those are the three mechanisms that might be responsible in the production of SIADH. This is going to be notable in patients with CNS disorders, or in patients with stress, or in patients with recent surgery, and malignant cells. Malignant cells can secrete ADH or perhaps ADH-like substances, and therefore they create an ectopic source for the production of ADH. Patients with malignancies or pulmonary infections may develop SIADH by this mechanism. And lastly, a lot of medications can cause SIADH by increasing the action of ADH in the distal tubules of the kidney, or increases the release of ADH. And the most common medications that have been associated with SIADH include your narcotic, your tranquilizers, your barbiturates, your general anesthetic agents. Thiazide diuretics could also do the same thing, as well as hypoglycemic agents, antidepressants. In SIADH, the body is unable to stop or to suppress the secretion of ADH, and it leads to a reduction in urine output. The key presenting sign of SIADH is going to be hyponatremia. In SIADH, you are not peeing at all. And so therefore, the water is going to be overflowing in your body, and you have fluid volume excess. And so this is going to be the key presenting sign of SIADH. It's going to be hyponatremia. And this is associated with the fact that you're not urinating, and it leads to your early signs and symptoms that are associated with hyponatremia. And they include your nausea, anorexia, weight gain, fatigue, muscle cramps, and urological symptoms. And these symptoms develop because of water retention, leading to water intoxication. Death can occur if your serum sodium is going to be very low. They say that if you have a serum sodium of less than 110, that this is usually a very bad sign, almost incompatible to life. The characteristics as far as laboratory values are concerned, as you could see over listed on the slide, are a decrease in sodium, a decrease in serum osmolarity. If you don't pee quite a whole lot, your urine is going to be dark yellow, and that would indicate that there is an increase in your urine osmolarity, as well as specific gravity that is present in the urine. The treatment of a patient with SIADH is to restrict the fluid, and we usually restrict the fluid by around 500 to 1,000 ml in 24 hours. Pharmacologic-wise, the meclocycline or lithium, and the action is actually to inhibit the production of antidiuretic hormone. The vaptans, like tolvaptan, is also found to be a vasopressin antagonist, or these have been found to be of benefit for patients with SIADH. Because we have hyponatremia, we're going to give hypertonic solutions. And hypertonic saline is usually given, particularly if the situation is such that the serum sodium is very low, less than 120 to 125 MEQs. This usually is going to be discontinued once the serum sodium is around 120 to 125. We don't want to be over aggressive in correcting hyponatremia, because this could lead to a breakdown of the blood-brain barrier. It's going to cause osmotic demyelination syndrome, which means to say that we're going to shrink so much the cells in the brain. This concludes our discussion on SIADH, or Syndrome of Inappropriate Antidiuretic Hormone. Thank you for watching, and please like, comment, share, and subscribe.